Gold Coast Hospital and Health Service, the mental health service, undertook our journey to zero suicide starting in 2015 as a result of a significant number of adverse events or deaths by suicide that have been occurring in our service. And it was really time for us to take stock and think about what are we doing and how might we do something differently. And particularly important for us to think about were there any evidence-based frameworks or any other information that we could draw on rather than just coming up with our own solution. So as a result of that, our clinical director did a significant piece of work around looking at frameworks that were available, and we found zero suicide in healthcare, and that really commenced our journey to zero suicide. So as a senior leadership team and being very clinically focused, the clinical director and myself led this piece of work across our mental health service. We felt that it was very important for us as clinical leads to go out to all of our team, to our clinical colleagues, and engage them in that significant conversation, because it is a significant change from what really has been a very pessimistic view of the inevitability of suicide to a significant change around optimism and some hope about we can actually do something about reducing and in fact eliminating suicide if we have the right skill, the right tools, and we train our staff. And I think about instilling that sense of hope in our staff was incredibly important, and also for the people that we serve, the people that come to us in distress. Now, it was an incredibly ambitious target, and it was really interesting because, we thought we'd get a lot of pushback about, how do you get to zero? It will be impossible, we'll never get there, all of those sorts of pushbacks that we were expecting. Very quickly, when we said to people, well, if it's not zero, tell us what number it should be. And people really resonated with that. Our clinicians said, well, actually, just like in aviation and in other zero-defect industries, how do you say one suicide is okay, but 2 isn't? Or how do you say 20 is okay, but 25 isn't? So it very quickly became apparent that zero suicide, despite being aspirational, was really the only target that we should and could sign up for. Probably one of the key learnings from the entire journey has been the importance of having fully engaged leadership. It's also having engagement with our board and our executive. We needed to understand and be assured that when we had a death by suicide, that it wasn't going to be what failed, who failed, but confidence from our board and our executive that they would believe in our processes, that we would openly review the incident of the death, what had led to it, what learnings we could find from it, and that we would ask for the family or the loved one's input into that review process. So that was very important, and we really had to do a lot of work around engaging our board and our executive to make sure that we could line up where we were going with where the hospital and health service was going from a culture point of view, because really a journey to zero suicide is a significant shift in culture. So following that, we did what most people do when they embark on a significant piece of change, is that they form a steering committee, which we did, and then we had champions or leads for each of the elements of the zero suicide framework. From there, we strategically picked our senior leaders, so our medical directors and our senior operations managers, to really lead in partnership those domains, because we felt that they needed to have the buy-in, and then we asked for volunteers or people who were interested in joining the working groups to drive those initiatives forward. We felt that that was very important because they brought their seniority in terms of their leadership, and they worked with the people who wanted to be part of their work group, and they really led that, and I think that helped from both making it a cultural shift, that the whole of the leadership group was signed up to this. It wasn't just the clinical director and the director of nursing and a few others, it was all of our leadership group. And that was very important for getting the traction that we needed, and I believe for sustaining it. We wrote a plan around how we were going to achieve this. It's our strategic plan 2015 to 2018, and that's really guided our work over the last 3 years. One of the other things that was really important for us as a service was to ensure that we took all of our opportunities to learn and really build our culture of being an inquiring, reflective staffing group, and that does fit with our hospital and health services ethos of being, a learning environment and a learning hospital and health service. One of the key learnings from all of this is that you cannot do this just as an aside to everyday clinical practice. You really have to have a very focused and deliberate piece of work around training for staff. We had set expectations and we were giving them tools that we then needed them to be able to use with the consumer who was in crisis, who was experiencing suicidal thought, who was sitting in front of them. They needed to be able to use those tools and use them competently. So we brought our staff offline for a day and did an intensive days training with them. And then when they went back into the workplace, we didn't just say, go forth and do this. We said, here are some very skilled clinicians who will walk beside you and work with you while you gain your confidence in implementing these strategies. So it wasn't everybody had to be assessed and everybody had to go through a particular process. It was driven by the clinician themselves. So they could say, I'd really like you to do one with me, I'd like you to watch me do one, or I'd like you to sit with me when I do one and give me feedback at the end of it. So we really tailored it, that translation to clinical practice from just a day in the classroom was incredibly important in terms of giving staff confidence in the new approach and being able to just help them understand what they're doing and what they're trying to achieve. From there, we developed our suicide prevention pathway, which is used by our clinicians when people present in crisis to the emergency department, and that really does determine the outcome for the consumer who's sitting in front of you. It's very much based around compassionate care and engaging the consumer, but also engaging their support person, their loved one, their family member, which is very important, particularly around doing things like collaborative safety planning, looking at reducing access to lethal means, those things that are specific interventions for people who are suicidal. It wasn't smooth sailing. It has really taken a lot of very focused work, very deliberate work. This was on top of our day-to-day full-time jobs. It's not instead of. So people were really trying to manage this. We had one project resource who really helped to lead and spearhead a lot of this. But I think the importance, and it can't be understated, is the importance of your clinical leaders going out and being there as part of the discussion, being part of the solutions when people are struggling with things, to help iron out the little kinks that we found along the way. We have spent a lot of time looking at our review process. So how do we make sure that we're learning from any incidents that might occur? And certainly what we've been looking to achieve, and we have, is a much more open process where the clinical teams who are involved in the care of the consumer are involved in the review of what happened, what could we have done differently, could we have done something differently? What can we learn from this? And the other piece of, information, or the other message staff gave us very much, was they wanted to be part of review processes, but they also wanted their colleagues to understand that by doing something different, they may not go through the same experience that they had as clinicians. So very, very powerful around sharing information, sharing lessons learned, and sharing improvements across our whole service. One of the issues that we found along the way was that staff needed different levels of support. It's not one size fits all. It really does need to be tailored to the clinician, because what we want at the end of that is for the clinician to feel confident and capable of having what can be quite difficult conversations with consumers and their families when everyone's in distress, trying to unpack suicidality. That's a really sensitive issue. So we really needed them to feel skilled and able to do that. That wasn't the same process for everybody. Some people needed more support. We ended up putting some of our very skilled clinicians on an afternoon shift, and in fact some of them in the early days did some nights, so that staff had someone, a touch point to go to and say, I'm not sure if I've done this right, I don't feel confident, or I don't feel comfortable doing it, can you support me? That's probably one of the big ones. One of the things that came out of conversations with our staff, which we call the voice of the staff, was very much around how they experienced the review process. And I mentioned that before, that they felt isolated from it. It didn't necessarily make sense to them. They were getting, or we were getting, recommendations that were hard to reconcile. As part of that, we changed our review process. At the same time as having that conversation, staff very clearly said to us, we know you're going to have to review this incident, but before you ask me or ask us, what did you do? What happened? Could you ask first, how are you? And that really resonated with us. That was just an incredibly powerful message. And I think that, in all my time as a clinician and as a director of nursing and mental health services, it was one of the most heartfelt messages I've had around staff wellbeing. And from there, we were able to work on a very specific piece of work around how do we support staff following an adverse event? Because we know, and the literature showed us, that there are in fact 3 victims when there is a significant adverse event. So the unexpected death of a consumer, there is the consumer and their loved ones. There's a second tier victim, which is in fact the clinician or the clinicians who are involved. And now in the literature it shows a third victim, which is in fact the organisation, because of reputational damage. We've done a very deliberate piece of work around developing a clinician response or a staff response to staff in distress. So immediately following an adverse event or a significant incident in any one of our services, our Always There responder team, who have been trained to do empathic listening, to go and support their colleagues, they are mobilised to go out to the team and to provide that listening ear and that collegial support. That has been incredibly powerful and really well received. It is something simple that the organisation can give back to their colleagues, to each other, that actually helps them to stay in the workforce. Timeframes. We were very ambitious around timeframes, and there's always a little bit of slippage. But I think probably the most important thing was that culture shift, changing it from being a tick box pathway to actually this is really how we do our core business for everybody who comes to our service, to our emergency departments. We did hear from staff about how we're going to fit this in. So some aspects of our current or our old assessment process were replaced with a new process. So some things were substituted, but there was no escaping the fact that this does take longer, because you're now no longer just assessing. You are assessing and providing interventions. So the safety planning initiative, the reducing access to lethal means, all of those initiatives add time because they need to be done with the consumer and ideally with their next of kin or their loved, their family or carer. So that does take time. And one of the things that we had to do is we had to tell our hospital and health service, we had to tell our emergency department colleagues that this will take longer. So there's no escaping that. But what we're trying to achieve and what we believe we've achieved is that this is business as usual now. So you don't do it if you choose to do it as a clinician. There is an expectation that you will complete a full assessment. The suicide prevention pathway is made up of some very specific elements. So there's an initial screening when the person presents. There is the usual, clinical data that is gathered. There is an assessment using the CASE approach, which is the chronological assessment of suicide events. And then there is a second step, which is around looking at risk. So we moved to using the Pisani formulation around preventative risk assessment and formulation. Staff will always use their clinical judgment, and they must. This was not to take away, the skill of the clinician in any way at all. It is an absolute tool for them to support their clinical judgment. From there would be a determination of whether the person requires the suicide prevention pathway interventions that are very specific. So if they go onto our pathway, they would be having a safety planning intervention, which is where they sit with the clinician and their family or carer, and they will collaboratively write a safety plan. The other one is around that conversation to do with access to lethal means. So understanding, do you have things at home in your environment that you might use if you've got access to them. And again, if you have, who's going to take responsibility for removing that? After we determine that the person can go home with their family or with their support network, then there is 2 follow-up visits. So one is done by our community team, our acute care community team, within 48 hours of presenting to the emergency department, and then within 2 weeks following that. That is to touch base with the person to go through, how are you going? Transitions are always a very important part of care because they're a high-risk time. And so part of that second follow-up visit or follow-up contact is to ensure that the plan that's been put in place is being actualised, that people are engaging with whatever the follow-up was. Once they've got past that initial crisis, and just to provide that ongoing support in the community, some of our people may go on to short-term case management with us, but predominantly people go back to the private sector. So it's very important for us to engage with our NGO partners, with our private providers, private psychiatrists. So a lot of work was done around ensuring that they understood what we're doing. So sessions were held specifically for private psychiatrists and private psychologists, so they understood what our pathway was, what we were expecting of our team, and really what we were expecting of them going forward.